Blue ones, I mean, it sounds pretty weird, but.
Yeah, what do we do without the technology? Because I live out just more rural area. But I find I never use it. I'm just gonna go ahead and get rid of it. And then when those things happen, I'm like, was that wise? Maybe I should have done it back up. But it got so expensive for something you never used.
Right.
Yeah. For some of our newer staff, when they were saying, the internet's down, how do we do any work? Right?
Oh, I
Contact
know.
people and you go, you see that box on the corner of your desk, it's called a phone. You can call them up. Who calls anyone anymore? I wish we called them. So you find
Okay, let's do a test here. Can those of you online or on the Zoom hear us?
Yes.
Yeah.
We hear you.
Okay, great. Okay, very good. We're going to go ahead and get started. We may have some others join us throughout. So, and although the agenda says that, I don't believe Terry's on. Is that right, Terry? Okay, Terry's not here. So I'm going to go ahead and get us started in her absence. So we'll call the meeting to order. Let's go ahead and do introductions. We'll start with those in the room. And if when you introduce yourself, you could indicate whether or not you're a MAC member or you're here as a guest or presenter. That would be very helpful for our team who is taking minutes. So we will start, Kim, with you.
Yes, my name is.
I'm sorry. There we go.
My name is Kimberly Brimmer. I am the director of the Pathways Program for OMPP.
I am Clarissa Lovell. I'm the Director of Operational Management here at the Office of Medicaid and Policy and Planning, and I will be presenting today.
Cora Steinmetz, Medicaid Director.
Kelly Mitchell, Director for the Division of Disability and Rehabilitative Services. Here is a guest co-presenter.
Kathy Leonard, I'm Director of Reimbursement for Medicaid.
Amanda DeRoss, Rules Attorney with FSSA.
Dr. Tim Hodges, United Healthcare Medical Director, Pathways for Aging, presenter.
Chris Callahan, CEO, United Healthcare, here as a guest.
Jessica Cromer, CEO for MDWise, here as a guest.
Brittany Berger-Mormon, Director of Medical Management with MDWise as a guest.
Dr. Shara Wesley, Chief Health Equity and Diversity Officer with MHS, and I'm a guest.
Hi, I'm Christina Hage. I'm Senior Vice President of External Relations for MHS, and I'm here as a guest.
Luke McNamee, Indiana State Medical Association, MAC member.
Blair Hadley with the Insurance Institute, MAC member.
Richard Nussel, Executive Director of Indiana Osteopathic Association, MAC member.
Great, thank you. And if you are joining on the Zoom, if you would please put your name and the organization that you represent in the chat, that would be very helpful. We see Shane Springer with the Dental Association, Katie Stafford Cunningham with NARF, Deanna Ferguson with the Optometric Association, Herb Hunter with the Pharmacy Association, Brian Musial with MDWise, Jessica Turner Stultz with the Chiropractic Association, Danielle Coulter with the Speech Language Hearing Association, Zoe France with the Council of Community Mental Health Centers, Brittany Mullaney, VP of Health Services for MDWise as a guest, Elizabeth Eichhorn with IHCA, Ryan Venice, Anthem presenter, Doug Bush with the Dental Association, Lisa Knowles, MDWise, Dr. Sarah Boslett, Indiana AAP, Ryan Kennedy filling in for Kim Williams with the Academy of Ophthalmology. Others that are here on the Zoom, if you'd please add your name to the chat for the record, that would be fantastic. So welcome, thank you for being here today. We've got a pretty full agenda, so we'll move quickly. But first I'll entertain a motion to approve the November minutes that were distributed. Any corrections or changes to the minutes? If not, do I have a motion to approve the minutes?
Motion to approve minutes.
Second.
Thank you. All in favor indicate by saying aye.
Aye.
Opposed? All right, the minutes are approved. With that, I will turn it over to Amanda DeRoss with the FSSA Office of General Counsel for a rulemaking update.
I was going to share slides and it's potentially
I
not letting
think-
me.
Deanna, we are seeing your screen perhaps. I'm not quite sure what this is. Well, it wouldn't be the start to a MAC meeting without a little technical difficulty, so let's see. Okay, give it a go again, Amanda. There we are.
There we go. All right. Good afternoon, everyone. Amanda DeRoss. I have 3 rules to present today. They are up on the screen. It's the CRMNF rule, LSA 23-727, LSA 238-819, Article 2, and LSA 24-58 nursing facility rule. I'm just going to do a quick overview of them, and then I can answer rule promulgation questions, and then we have subject matter experts if you have any substantive questions. First rule is CRMNF. I presented this last time. This proposed rule amends 405 IAC 1-12-21 to increase the rate paid to any Medicaid enrolled large private intermediate care facility for individuals with intellectual disabilities that is licensed as a comprehensive rehabilitative management needs facility. This rule was submitted to the Office of the Attorney General on January 31st of this year. And once the Office of Attorney General approves it, they will submit it to the Gov's office for review and approval. Does anybody have questions about that rule? Great. Let's see, the next rule is Article 2. This is LSA 23-819. This proposed rule amends 405 IAC 2 concerning updated definitions, guidance, and clarification of terms, and will align IAC with federal code. A public hearing was held on January 29th of this year. OGC and OMPP are reviewing the public comments that we received at that hearing. We're preparing the agency response to those comments, and we are making amendments to the rule language in response. Following that, a notice of second public comment period and hearing will be posted on the Indiana Register and the FSSA website. Does anybody have questions about that rule? Great. And the last rule is the nursing facility rule. This is LSA 24-58. This proposed rule amends, adds, and repeals rules at 405 IAC 1 concerning fee-for-service nursing facility reimbursement. A notice of first public comment period and hearing was posted yesterday, February 21st. And following that, a public hearing will be held on March 25th. Does anybody have questions? That concludes my presentation. Thank you.
All right, thank you, Amanda. Okay, we will keep going, and if you'll just bear with me a minute, we're going to kick over to my slides here. All right, very good. So thank you for joining us today. And with us, I'm joined by my colleague, Kelly Mitchell, as she introduced herself, who is our Division of Disability and Rehabilitative Services Director, and appreciate her being here with us today to discuss some Medicaid updates that we have to share with you. So this is our first MAC meeting that we've had since we shared the Medicaid forecast in December. So thought that it was appropriate to spend a little bit of time talking about the forecast and some of the sustainability strategies that have been recently announced last month to address the variance that was discussed in the December forecast. So from the time that the forecast variance was identified in late November, the work of FSSA across the Medicaid division and really all of our leaders throughout DDRS, the Division of Aging, our Chief Financial Officer, Paul Bowling, we've come together, and our work has been really broken into 2 different components. The first is a series of cost containment or sustainability strategies that address the immediate fiscal situation that we are experiencing in this biennium. The bulk of the presentation will be to go over those sustainability strategies, but I wanted to first spend a few minutes speaking about some of the other category of work, which really has to do with improving the accuracy and reliability of the forecast the assumptions that are used in the forecast, and enhancing our financial reporting structures and budget monitoring. As you can see, the overall objective here is really to ensure that we have a reliable forecast that can assist in building out the Medicaid appropriation budget. But there are multiple components to that. In looking into sort of the drivers of what created such a variance from the April 2023 forecast to the December 2023 forecast, we recognize that the agency has an opportunity to enhance our review of the underlying actuarial assumptions that both programmatic and financial staff use in assisting with our actuarial vendor to build out the forecast, and working to decrease the data lag in the timing of what data is used. Of course, we're always going to run into issues with claims run out and reconciliations, but to the extent we can decrease that data lag, we will have more real-time information to use in our forecasting process. We're also building in a series of processes to really identify emerging risks, not just to the Medicaid program, but forces around the healthcare market generally. Paul Bowling and I have also begun a process to improve our financial reporting in terms of the transparency and the amount of information, the level of detail that's used in terms of the utilization and information at the service level specificity. We also have instituted a policy change review process so that across all of FSSA, and particularly those areas where Medicaid dollars are used, we have a robust process where we review policy changes on a prospective basis to make sure we have an understanding of the fiscal implications of those changes. And then again, to ensure that we have regular reporting that we'll share with legislative fiscal staff, legislators, other policymakers, stakeholders like yourself, including the MAC. With that, we'll turn to this, the specific sustainability strategies that were announced on January 17th to address the current variance. This particular strategy has its own slide because it is the only one that is broad across the entire Medicaid program. We're going to speak a little bit more about our specific strategies on the aged and disabled waiver, but this strategy really, oops, I'm sorry, just slipped ahead on the slides, really goes across the entire Medicaid program. So these, you'll recall, and we have presented to this group about our rate matrix process. You'll recall that that is a kind of fancy word for the schedule by which we update and rebase rates. Kathy presented on that in the last meeting. And so within the years in between that rebasing or rate review, we had planned for a 2% index on an annual basis for certain providers. You'll recall that there are other providers who have a statutory or regulatory methodology for how their rates are calculated, and they are not included in this. But these 6 provider types are the ones that would have been up for an annual index within this biennium as part of our rate matrix. So we have announced that we will be pausing on that rate index as a cost savings measure. This is an area where we feel that pausing on an increase that has not yet happened is a more favorable solution than taking rate reductions or cuts in other spaces. So these 6 provider types recently had their rates updated and for the most part increased, which is why we feel that this is an appropriate solution until fiscal situations improve. As I mentioned, the other sustainability strategies have to do with our aged and disabled waiver. So I've included just a quick overview about that waiver for those of you who may not be familiar with it in your day-to-day work. So it's one of 5 home and community-based services waivers administered by the FSSA. I've included here the eligibility criteria for this particular waiver. Notably, the individuals on this waiver must meet nursing facility level of care. In place of prior authorization or other types of things that we think about in state plan Medicaid, on this HCBS waiver, a service plan is developed and completed by a case manager, care manager, through an area agency on aging or independent care manager. And that service plan serves as the authorization for waiver services that are determined to meet and be appropriate for that individual's specific needs. That's just a little bit of a primer on the A&D waiver so that as we talk about these sustainability strategies, you have a little bit of context for what we're discussing. So this slide outlines those specific strategies. And the reason that the strategies related to sustainability primarily focus on this waiver is because this is where we saw the most, I should say, the greatest amount of unexpected increase in expenditures. So throughout our forecast strategies, what we attempted to do was really ensure that the solutions that we were coming up with were narrowly tailored to address the forecast and financial situation that was discovered in December. So the first item here is the one that has garnered the most public attention, and we'll give some specific updates around that. So I'm actually going to pause on that for a moment. We've got a whole series of slides afterwards, but I want to just highlight some of these other A&D waiver strategies that we are working through. So first, the agency will adjust which service plans on this waiver are auto-approved and which service plans are reviewed by state staff. You'll recall from the last slide that the AAAs and our independent care managers help develop those service plans for the individuals. This allows us to have a little bit more insight, particularly on those very high utilization service plans, to ensure that the services that are being authorized under the waiver are appropriate for the level of need for that individual, not more, not less. We've also discovered within the A&D waiver that we have an opportunity to reinforce practices to ensure that the services are approved and provided in a manner that's consistent with the approved service definition for that waiver. So this waiver, of course, is approved by CMS and our federal partners. And so this is an opportunity for additional training to ensure that services like specialized medical equipment, home modifications, vehicle modifications, that those services are being applied in a manner that is consistent with how we have it defined within the waiver. Their enrollment on this waiver has grown, but not at a pace that really explains the rapid increase in expenditures. It's been much more in the space of utilization than enrollment, but pediatric enrollment in particular has grown at a much more rapid pace on this waiver. So that has caused us to take another look at the level of care tools that we use and make sure that they're really appropriate for the pediatric population. You can imagine that as we look at assessing individuals and their needs associated with activities of daily living, like eating, bathing, dressing, what we would expect a child to be able to do is very different than an adult. So making sure that the tools that we're using are appropriate for the pediatric population. A non-allowable practice had also evolved on the A&D waiver, whereby providers were offering waiver services at risk once level of care had been established, but perhaps not Medicaid financial eligibility yet established. So we are stopping the retroactive coverage of waiver services to make sure, again, that we're aligning with what is authorized in our federally approved waiver. And then finally, we have already taken this step of pausing the expedited waiver eligibility process. This was similar to in the retroactive coverage area. If you think of Medicaid presumptive eligibility, EWE was very similar for the waiver services. We ran into some operational challenges when it comes to the types of things that must be collected from a CMS perspective around Social Security number verification and citizenship. So we're taking a step back as we work through those operational processes, ensure we have appropriate data monitoring in place, and then we'll look to find other ways to speed up that eligibility process in a compliant way. Okay, so I'll pause there for any questions thus far before we get into this next issue. And I'm sorry, I'm not doing a great job monitoring the chat, so just want to make sure. And Kelly is also welcome to jump in at any point.
No.
Okay.
Just trying to.
All right, very good. Okay, so we wanted to spend some time talking about this particular issue because it has garnered a very good bit of public attention throughout the legislative session, in the media, et cetera. So paid caregiving by legally responsible individuals. And if you'll bear with me, this is again an area where I'll try to do some level setting and then we can talk about the path that we're on related to these changes. So legally responsible individuals are defined by federal regulations and CMS as the parents of minors and spouses. These caregivers will still have a mechanism to provide paid care for their loved ones under the waiver, but the service name and the payment methodology, the way that they are paid, will change on July 1st. Today, legally responsible individuals are primarily providing the service of attendant care. We will be transitioning away from this model to the service of structured family caregiving. We have a Medicaid strategies website that has a lot of information on it that we'll be sure to drop into the minutes and can share with our MAC members as well. But there's one specific document that I'll reference here and would point you to if you have questions about attendant care and structured family caregiving and the differences between them. It's a side-by-side comparison that really compares and contrasts the two different models. So I'll highlight a few things about that are included on this side-by-side, and we can send it out as well for anyone who would like to take a closer look at it. Tried to, let's go to the next one. Bear with me here. It's probably going to jump ahead a whole bunch. Okay, there we go. So this kind of puts into perspective this particular issue. We have 2 million Hoosiers on Medicaid currently. 42,000 individuals are on this particular aged and disabled waiver, and right about half receive the service of attendant care today. In the polka dot color on the far left-hand side of that, the bottom of the funnel, that's the pediatric population. So right about 1,600 pediatric individuals receive the service of attendant care today. 2,000 individuals of differing ages receive the service of structured family caregiving. So just want to put that particular slide in your mind as we talk about these changes. This is very similar information, but in chart format. So only about 8% of the attendant care recipients on the A&D waiver today are children. You can see 64% are ages 60 and up. This is the you can see in the bottom chart, the expenditure growth over time. And again, this is really why we are taking steps to come up with a more fiscally sustainable solution that still supports individuals and their levels of need, but in a way that reduces the current rate of growth. In state fiscal year 2022, attendant care expenditures across all ages was about $317 million. In the current state fiscal year, we are projected to spend $1.4 billion on this service of attendant care for the 21,000 individuals who are currently receiving it. You can see that the rate of growth is especially steep in our pediatric population. Again, around 1,600 children receive attendant care on the A&D waiver today. Attendant care expenditures in state fiscal year 2022 were a little less than 10 million. We're now on track to spend 172 million for that population. And enrollment continues to grow in our pediatric population on this particular waiver. This slide depicts similar to what we just discussed, but what I would point out is this particular graph includes the number of hours or utilization. You'll recall that I mentioned in the pediatric population, we see a good bit of enrollment growth, not so much in the all ages population, but what we do see is a very stark increase in the number of hours that an individual is receiving of attendant care. This is an hourly billed service. The maroon coloring is expenditures for an individual receiving 40 to 60 hours of attendant care, and the gray at the top, I know it's a little hard in the room here to see, the gray coloring at the top of each of those bars represents expenditures for individuals receiving 60 plus hours per week of attendant care. We see expenditures for individuals who are receiving 80, 100 hours per week of this particular service, which is really driving the increase in expenditures. You can also see the jump in July of 2023, which has to do with our home and community-based services rate increases. You'll recall that HCBS services were one area in our rate matrix where we have recently updated rates. This chart normalizes the growth of attendant care expenditures for that rate increase. So the gray bar, part of the bar represents the rate increase, but you can still see increased growth due to utilization throughout July through December. This chart is specific to our pediatric population. So you can certainly see there the stark increase starting in about March of 2022, which aligns with timing of when a publication was put out reinforcing the agency's policy at the time to allow legally responsible individuals to provide the service of attendant care. And from there, the growth has really increased over time. The scale is smaller here. As you can see, with the expenditures are a little less than 16 million per month as of December 2023. But again, what's notable here is the very high number of hours for the pediatric population, where nearly half of the expenditures as of 2023, or I'm sorry, December of 2023 for children were for those receiving 60 or more hours per week of attendant care. This dives in a little bit more into the specifics of the two services. So these are excerpts from that side-by-side document I referenced, and hope that this is helpful in explaining a little bit more about these two services. So today, again, legally responsible individuals, which is parents of minors and spouses, are providing the service of attendant care. We will transition to the service of structured family caregiving. Both of these services are hands-on assistance with activities of daily living, bathing, dressing, eating, getting around the home. The big difference between this and what generates the sustainability is, again, attendant care is paid on an hourly basis and structured family caregiving is a daily per diem. What's notable is that neither of these services are skilled nursing or home health. This is an unskilled service from a caregiver. The change from attendant care to structured family caregiving does not impact that waiver member's ability to receive other services on the waiver. We've got many of those listed here. Again, those are your home modifications, specialized medical equipment, transportation, and case management. And it does not impact their overall Medicaid health coverage for services that we think of, like their physical therapy, occupational therapy, hospital, pharmacy, et cetera. Again, here's the breakdown of from the financial perspective between these two services. So the hourly reimbursement today for attendant care is $34.36. The structured family caregiving per diem reimbursement is based on 3 different tiers that are assigned based on an individual's level of need. The care manager completes an assessment for that waiver member, and the scale is graduated so that a higher level of need for an individual receives a higher per diem. Under both services, the Medicaid program pays a provider service agency who then compensates the caregiver. So this is not a service whereby the caregiver is directly contracting with the Medicaid program or receiving direct reimbursement. So to that end, we have included on the side-by-side the assumptions that FSSA has used in creating these rates about how much is passed on to that direct caregiver, since that has been an area of discussion and concern. Under the structured family caregiving service, we anticipate that the caregiver payment is in the 65 to 70% range of that daily per diem. On the next slide, we'll show a chart that kind of compares and contrasts what that looks like under a couple different scenarios. 2 other things I want to call out about this slide is that within the service of structured family caregiving, respite care is included in what the structured family caregiving provider must assist the family with. And under both attendant care and structured family caregiving, the IRS treats those payments to the legally responsible individual as difficulty of care payments that are excludable from gross income for taxation purposes. This is the slide that really compares and contrasts what it looks like under different scenarios. So one thing that I'll call your attention to is we, again, at FSA don't have the transparency, or we don't receive the data around how much the caregiver receives in reimbursement. Again, under structured family caregiving, we anticipate in that 65 to 70% range. But what we have heard from caregivers is that $15 an hour is a typical level of compensation under attendant care. So what we've done here in this chart is really show what amount the provider agency is receiving today under the attendant care hourly rates based on the number of hours that an individual is authorized for. And then of that amount, what we believe the caregivers are likely to be receiving. And the same assumptions around the provider agency amount and the caregiver amount for structured family caregiving. So you can see that an individual today who's providing 40 hours per week of care, assuming that they are compensated at $15 an hour, is the caregiver or the legally responsible individual is receiving a little more than $30,000 per year. That's comparable to under a level 3 structured family caregiving, what the per diem will be for the caregiver right there at about $34,000 a year. So I know I've put a lot of information out there. I also will check the chat to see if there are any questions, but any questions from anyone in the room or questions online? Kelly, anything you want to highlight or add?
I think you covered it quite well.
Okay. Thank you for sharing that. We'll continue to keep you all updated as the sustainability strategies evolve in future MAC meetings, especially as we deploy some of those other areas that we've talked about towards the beginning of this presentation. With that, I think we are ready to transition to our Pathways update.
Thank you very much. We wanted to kind of just thank you for the opportunity to kind of give you an update of all the activities. We've been very busy in getting preparation for the go live of Pathways. And in doing that, we want to kind of give you highlights of some of the activities that we really have been focusing on. In addition to our readiness preparation, we also have really been focusing on stakeholder engagement and communication as one of our key priorities in helping with this transition. In doing that, we're going to pass it over to Shayla from our communications team, who has prepared some videos that we are using for outreach.
Hello, I'm Shayla Penner. I am the Deputy Communications Director working with Pathways. And as Kim said, before we start into our stakeholder engagement, we just want to show you one of the videos. This is for providers that we are working on. We have several items available on our website, on the in.gov Pathways website, that are available for members, partners, and providers to get more information, to share more information. We also have a full FAQ section, and we continue to update that pretty regularly, but we just wanted to kick off the engagement piece with this new video.
Indiana Pathways for Aging is the state of Indiana's new managed long-term services and supports program. Indiana Pathways for Aging is for Hoosiers age 60 or over who have Medicaid benefits, including Hoosiers who are also eligible for both Medicaid and Medicare. Indiana Pathways for Aging will utilize health plans to help older Hoosiers receive the care and services they need to live their lives and be able to age in the setting of their choice. The state estimates that more than 120,000 Hoosiers will be eligible for Pathways. They will include Hoosiers age 60 and over who are eligible for Medicaid, including residents of nursing or long-term care facilities, and including residents receiving home and community-based services. Members can be dually eligible with both Medicaid and Medicare, and they can be receiving home and community-based services as well. Pathways members will get to choose between 3 health plans that will coordinate their care. These are Anthem Blue Cross and Blue Shield, Humana, and United Healthcare. Each of these plans will coordinate and pay for doctor appointments, hospital visits, and medications. They will also provide dental and vision benefits and non-emergency medical transportation. Each of the Pathways health plans offer additional services to their members. These services vary from health plan to health plan. Pathways members will need to look at each health plan and pick the one that best meets their needs. There are 2 simple steps to enroll. Step 1. Watch for a letter in February or March 2024 from the Indiana Family and Social Services Administration. The letter will provide more information about the different health plan options, along with the Pathways phone number. Step 2. Call the Pathways phone number on the letter to pick a health plan. A representative is available to help members learn more about their options. Visit in.gov/pathways to learn more about the program and how it might impact your patients and clients. Compare the Pathways health plans and talk to your patients about which health plans you participate in to help them make an informed choice. Please be informative, but remain impartial as members make their plan choices. Health plans offer the same basic benefits, but can vary in their added benefits. Depending on the situation and health needs, one plan may suit a member better than another. It's important members review the options and select the plan that is right for them. Hoosier Medicaid members who are 60 and over and receive long-term services and supports will need to pick a plan before the program begins. For those qualifying Hoosiers who do not pick a plan, one will be selected for them. Here are the important dates to know as Pathways gets underway. This is the time frame when qualified Hoosiers begin receiving a letter about the program and how to pick a plan. Some individuals may also get a phone call from FSSA's enrollment program. This is the deadline eligible Hoosiers must pick a plan. If they don't pick a plan, FSSA will pick a plan for them. This is the time frame when members will be hearing from their health plans and will receive a welcome package. This is the time frame when Pathways health coverage begins. To learn more, visit in.gov/pathways. Thank you for supporting older Hoosiers in choosing to live life their way.
To go back to this slide.
Okay.
So we produced this, as you can see, and we have a member-directed video as well as a provider-director, just to assist in the explanation and the communication so that everyone is clearly understanding of the Pathways program. As we said, they're available on the website as well as some of our providers have downloaded.
Chair of the commission is here. We have a jam-packed agenda, so we'll go ahead and dive right in.
I started playing a different meeting.
Yeah, that's
So if you wanted to hear the Behavioral Health Commission meeting. Sorry, Kim.
In addition to these videos, we also are doing a lot of outreach to our stakeholder engagement as well as other communications. And one of the areas of focus that we have realized that would be helpful in this transition is some increased trainings directed towards our providers. We have a slide here kind of highlighting some of the initiatives that we have already started as well as we're continuing to start. Some of the areas that we've noticed that is to smooth the transition was to do, try to do trainings on Pathways contracting for our providers to make it a smooth transition into the MCE programs, as well as to make sure that we have the network available for the Go Live program. After hearing through that, we also did a provider educational program on the enrollment process for the members. We view the providers as being a key partner with us to ensure that all of our members are able to transition into the Pathways program smoothly. And so we did webinars as well on that. The future webinars that we'll be producing and that we are making available to our providers as well as associations and other stakeholder groups are claim submission trainings, as well as service coordination trainings and authorization trainings. So these are some of the highlighted areas that we have seen that we think that it would be, in addition to the Q&As that we have available on the website, as well as the MCE direct to provider trainings that we have been able to develop to help make this transition smoother. In addition to the trainings, we also are doing direct to stakeholder engagements that we have already started to do, and these are just a list. We view that having that open and the open engagement with our stakeholders will help it make much more of a transparent communication process, as well as making it available so that they can have explanations of our whole enrollment process as well as our transition process. Here are some highlights of some of the different engagements that we have. We are making it a point to be available for as many engagements that we feel that can reach people at their locations to help with this transition. We also have the roadshow that we do, and we will be going throughout the state to do provider engagements, and we'll be providing both the pathways and access to the MCEs at roundtables for those. In addition to this, we also have a whole outreach program aimed for our direct to consumers. So highlighted here are scheduled. We will be going around the state at different venues. This is just the preliminary list. There'll be an additional list available going forward that we will be doing all throughout the north, central, and southern part of the state. And we will be providing these so that the members have that opportunity to talk to us one-on-one and understanding how they can enroll into the Pathways program and if they have any questions that are occurring in that enrollment process. So highlighting those communication and engagements as a focus, I want to pass it along over to Clarissa so she can talk about our enrollment activities that we are doing as well as our readiness activities.
Thank you, Kim. Next slide, please, Cora. So briefly, I wanted to remind everyone of the Pathways enrollment timeline that is driving our member and provider engagement that Kim touched on in her previous slides. So real quickly, February to March of 2024, that's when members who are eligible for the Pathways program will start to receive those plan selection notices from the enrollment broker. And then members who currently reside in a nursing facility or who are receiving HCBS services will also begin to receive phone calls from the enrollment broker, just reminding them to select a health plan for Pathways. And then March through April 2024, members can still continue to call and make those plan selections. And then if a plan is not selected by the end of April, the beginning of May, then the member will be auto-assigned. But please keep in mind that even if the member is auto-assigned a health plan, they still have the option to call the enrollment broker and select another health plan if they choose. So in May 2024, members will receive a 60-day notice, and this notice just confirms the health plan that the member has been assigned to or that they have chosen and how they can contact that health plan if they have any questions. And then in June 2024, members will begin to receive a welcome packet from their assigned health plan, which will include items such as their ID card. And then of course, in the summer of 2024, around that July timeframe, that is when Pathways coverage becomes effective. And those who are eligible, who are currently in Hoosier Care Connect or in fee-for-service, will transition into the Pathways program. Next slide, please. All right, so FSSA enrollment broker will begin sending out notices. So members and their authorized representatives should start seeing notices in their mailbox within the next 7 days or a week. But please keep in mind, this is an estimate. It would depend on the postal carrier who will be delivering the mail when they would receive the notices. And I wanted to highlight that prior to notices being mailed out to members, we here in OMPP have been engaged with the enrollment broker for their own readiness review, similar to what I'll touch on with the MCEs later. And as part of that readiness review, we have reviewed the enrollment broker's call scripts, trainings, systems demonstrations, and even listened to these initial calls that are coming in to better prepare the enrollment broker for the Pathways enrollment activities. In addition, you all can find copies of the notices that will be mailed out from the enrollment broker on the Pathways website, and those are up and live now. And to echo Kim's point that she spoke to earlier, we had a Pathways notice webinar, and we held this webinar regarding the member notices where we spoke to providers about the following items. Next slide, please. And through that engagement, we wanted to remind providers of the changes coming and how they can better educate and serve their members before, thank you, oh, you're fine, before July in the summer of 2024. And we also, through that webinar, explained the specific notices that members may receive and how they can better interpret those notices to assist their members or their authorized representatives of those that they serve. We also reminded providers of the enrollment broker helpline number for the Pathways program, and we provided them a list of items that a member or their authorized representative will need before calling the enrollment broker, such as items to verify the member's identity, which includes a social security number or their Medicaid case number, as well as the member's primary medical physician. And these items will help the enrollment broker better educate the member on what Pathways health plan is the best choice for them moving forward. Okay, next slide, please. All right, so now I will briefly share with everyone an update on readiness review, as well as we wanted to provide additional information on our readiness review processes. Next slide, please. All right, so what is readiness review? So readiness review is a systematic large-scale review where we review the MCE staffing, policies, their systems, and of course their network adequacy, and the list goes on and on. So readiness review safeguards that the MCEs are compliant with the scope of work and that they are ready to uphold our strict requirements and expectations around the Indiana Pathways for Aging program. So we developed to meet all the requirements of the CFR listed there, which is 42 CFR. And again, we do this to ensure that the MCs understand the meaning of the program and how to assist Pathways members to really ensure that the goals of the program are being met around participant choice, quality, and sustainability for our members. And of course, readiness review includes desk review, which is items submitted through our online platform, which includes policies and procedures, as well as live demonstrations where the MCEs will demonstrate their system capabilities. Next slide, please. Excuse me. All right, so as I mentioned on a previous slide, readiness review includes both desk review and on-site demonstrations. So this slide here gives an outline of how we review a desk review item. So MCs submit documentation to verify their ability to meet readiness review requirements. And again, desk review items include initial policies and procedure, member materials, provider contract templates, website content, and so on. Documentation is submitted to validate compliance, and that's against the scope of work, federal and state regulations, as well as any bulletins or modules that FSSA currently has out and released. So at least 2 to 3 FSSA subject matter experts participate in the desk review for readiness. And I really want to highlight this point here that readiness review is an agency-wide effort where we get support not only from our office, which is the Office of Medicaid Policy and Planning, as part of the reviews, but we also get that great expertise from the agencies such as the Division of Aging, DMHA, and DDRS as we review items submitted by the MCEs. And an example of a desk review requirement is below. And here you could see that in one column, we call out the preferred drug list and the formulary requirements. And then we list those specific readiness review requirements that the MCEs must submit documentation for to show that they are fully compliant with that ask. And you can see that one of the items there is submit the PDL to OMPP Pharmacy, where they will review and then they determine if they are compliant. Next slide, please. All right, on-site demonstrations. So MCEs demonstrate their internal processes, and then we verify if those demonstrations meet our expectations for that requirement. And this review ensures that the MCEs have the ability systematically in order to fully carry out the items listed in the contract. So again, on-site demonstrations, they validate compliance with the scope of work, state and federal regulations, as well as any provider modules or bulletins that have been released. MCE staff provide live demonstrations of their system during on-sites. And then of course, we listed some examples below, again, keeping to the pharmacy theme here. And we call out, demonstrate the ability to pay pharmacy claims. And then we have listed examples of certain claims, scenarios that the MCEs had to live demonstrate in their claims platform to ensure that they would get the expected output from those claims that we at OMPP would expect for them. Next slide, please. All right, so topic schedule. So, and to ensure consistency with the MC documents and readiness materials, we here at OMPP, we developed a topic schedule that really looks at the scope of work and separates out of certain topics over the months up until we go live with the Pathways program. And the desk review and on-site topics are separated by that topic schedule. And then we'll go over that outline in the next 2 slides. All right, so here's an example of current topics that we have done for July 2023 and so forth. And that's when our readiness review efforts began there in July of last year. And you can see that we started with the staffing plans with each of the health plans, of course, a list of subcontracts. And then we get on really into the meat of the scope of work and the Pathways program. And we get into care and service coordination overview, provider materials, enhanced benefits, and member marketing materials, care coordination plan, and of course, provider network adequacy, continuing on through January of 2024. And then the next slide shows where we're at for the month of February and what we are currently in the process of reviewing. And that includes real quickly items such as covered benefits, non-emergency transportation, behavioral health, and Medicare integration and pharmacy. And then in the future months, we will be reviewing items such as the information systems, claims, provider network validation. And you see provider network validation on there for multiple months because provider networks are important. And we want to make sure that our MCEs are continuously contracting throughout the whole way before Pathways goes live. Those staffing plans, and then in May 2024, you see that whenever we will do final demonstrations or final resubmissions of any on-site materials or desk review items that we would like to see the MCEs redemonstrate to us that they are ready for the Pathways program. But please keep in mind that with all these topics listed and all through the readiness effort, our MCEs are engaged in other activities leading up to Pathways Go Live, such as systems testing with vendors such as our core MMIS, which is Gainwell, and our Maximus enrollment broker. So there are other systems testings going on that aren't listed here as part of readiness review that we have oversight of. And I also wanted to note that you may see there in May 2024 it says final resubmissions and final demonstrations, but that does not mean the end of our oversight. So we continue our oversight of our programs ongoing on a monthly, quarterly, and daily basis through reporting of our quality reports that are submitted quarterly, as well as monthly on-site reviews on various topics. And we continue that oversight through those mechanisms as well. Okay, next slide. I think that's the last one.
Great. Thank you, Kim, and thank you, Clarissa. We'll be happy to take any questions about where we are, but I just want to synthesize a few things that you heard here as well. So members who will be in the Pathways program are receiving their plan selection notices starting now, this week. So if you are a stakeholder or provider type or represent individuals who do, please check out in.gov/pathways. There's a ton of information there. I just have to give huge kudos to the team who's presented here, as well as our FSSA communications team, who has worked really hard to develop toolkits. And how many times has the toolkit been downloaded? It's up to a really high amount. Shayla's in the room still, but so we've had 170 times that promo toolkit has been sent out about the Pathways program. The Enroll Now part of our media campaign has now gone live as well. So you might see transit authority buses that have the Pathways number on it, and encourage people to call the enrollment broker and make their plan selection. So if there's support that we can offer to make sure that you and your constituencies have information in hand to support members as leading up to the July 1 go live, please let us know. We are here for that. And as you can see from Kim's slides, we're trying to do both a grassroots, boots on the ground type of approach with members, as well as making sure we have appearances at key events and association meetings and the like. So happy to engage with you all if you have an event that we aren't already planning to be at. And then hopefully from Clarissa's slides around the readiness activity, you can really see the very granular level of detail with which we conduct our readiness review. And so since we have the MCEs in the room, I think that they can attest to the level of scrutiny that takes place from OMPP as we do these readiness activities. And as you can see, a lot of work has already taken place in this, and we have a lot of work to go yet until July 1 to make sure that we have a very smooth program launch. So happy for myself or the team to take any questions around Pathways at this time. Get my chat up here. Okay, and you're also welcome to also reach out to Medicaid at fssa.in.gov if you think of things afterwards, or myself. We are appreciative that we are joined today by our 5 current managed care entities who we have asked to provide an update around their case management activity and the work that they do to support members via their own programming that they might have, or specific medical management practices. And so each of the 5 MCEs has a representative here or online, and are going to spend roughly 5 to 7 minutes walking through their approach to this important work of how we support our Medicaid members in Hoosiers. So I think first up, we have Dr. Venice from Anthem.
Hi, good afternoon.
Hello, I have everyone's slides as well, so I will be happy to, if you just prompt me to share the next slide. With that, thank you for being here. Take it away.
Excellent, thank you. I'll come on camera. Just a little anecdote as I search around for my reading glasses. I practiced my whole career at St. Vincent as a young staff. I used to kind of gently rib my senior partners when they would grab their reading glasses to read EKGs or write in charts. And as I was panically looking around for mine, as I was bringing my notes up, I realized 20 years later, that's probably not a nice thing to tease people about. So I'm sending out into the ether an apology to all my partners out there. So, but thank you. I appreciate the time today to share what we're doing around case management. And I felt maybe the best way to do that is just to tell a story. And actually, if we move into the next slide, what I want to tell today is a story about one of our members named Mary and one of our behavioral health case managers named Ashlyn. And the story I'm going to highlight is how Ashlyn walked with Mary from really a place of hopelessness to hope. And to set the stage, Mary is a 21-year-old who has been diagnosed with bipolar disorder and major depression and also PTSD. And because of some prior negative experiences with healthcare professionals, Mary really has sort of developed, I guess what you would best consider a level of distrust and sort of a sense of doubt that really healthcare professionals in general have a care for her well-being. She really has described to Ashlyn a sense of unease when it comes to interacting with the healthcare system. But despite this, she's always tried to do what's been asked of her. She really wants to do what's best for herself and for her 2.5-year-old daughter. Unfortunately, she's really encountered some tough times in life and more recently, some really significant life stressors. And that led her to have a manic episode, which required an inpatient hospital stay in order to stabilize. And while she was inpatient, she learned that she actually lost custody of her daughter. And so needless to say, she was pretty devastated about that. She also learned while she was undergoing care that one of the conditions to regain custody was that she was going to have to undergo some pretty intensive outpatient management, scheduling and attending several evaluations. And unfortunately, the healthcare facility that she was in when she was ready for discharge didn't really help her much in getting that arranged. So they really left someone that was, you know, in a rough spot to start, was already distrustful of kind of healthcare in general, to make those arrangements on their own. So per our protocols, Mary's discharge triggered an assignment to one of our behavioral health care managers, and luckily she was assigned to Ashlyn. When Ashlyn first contacted Mary had already tried to contact multiple providers and tried to set up that initial appointment with a mental health provider for that initial evaluation. And what she had been told over and over again was that the first appointment that she could arrange was going to be 2 or 3 months away. And of course, knowing that that was one of the initial conditions to regaining custody of her daughter, you know, this was really upsetting. And when I was talking to Ashlyn about this situation, she said one of the first things she sensed about Mary was that she just seemed hopeless and that she seemed scared and that she was really just disengaged at that point from the whole situation. And she really felt that Mary thought the whole healthcare system was working against her. Ashlyn was astute enough to recognize that this was a pretty serious situation. And the first thing she did was just reassure Mary. And then she spent the next 2 hours on the phone with her, just talking with her and just assessing the situation and then reassuring her that they were going to work together to find a solution. So what they came up with was that in lockstep, they were going to start calling providers together. And with Ashlyn's support and the advocacy of having that joint call and being able to explain the urgent need for this, initial visit together, they actually had 2 viable options within only a couple calls. And the first one was an in-person evaluation the same week. And the second was actually a virtual assessment the same day of their call, just actually a few hours after they reached the provider. So obviously both of those options were a far cry from the 2 or 3 months that Mary was being told that she was going to have to wait by the numerous providers that she had contacted previously. When I talked to Ashlyn about this situation, she said it was pretty amazing that suddenly Mary's hopelessness was turning into hope. And she was amazed when when Mary said that she felt confident at that point that she wanted to actually research these options on her own. And she wanted to take the next steps of deciding which of these options to take independently. And so Ashlyn left her to that. She said that she felt confident that she was going to be able to do that. And at last follow-up, Mary had done that. And even though she was still working through some other health issues, unfortunately, Mary also has some physical health issues that have plagued her for a while too. But she's also working through those and still taking the necessary steps that she needs to take to regain custody of her daughter. So I think overall, just as importantly for what this shows about Mary and how case management can really take someone who can go from a state of being really disengaged and hopeless to really being engaged in their own care. It also gives our case management a sense of accomplishment and pride so that when they face similar situations in the future, they're going to be able to grow and face these situations with a lot more confidence and pride in their work. And with that, I'll be happy to take any questions. And I'm also happy that I found my reading glasses.
Can you hear us okay now?
Yes.
Okay, thank you. All right, I hope everyone can hear me all right. My name is Shannon Slater. I'm the manager of our life services team here at CareSource. So first, this is my first time in front of you all, so just thank you to the committee for letting me come and share the work we do here as a life services team and how we're supporting our Medicaid members. So if we can go to the next slide. So I'm just gonna, I know I need to go through this quickly, so I'm just gonna do a quick overview of our history, our mission, and what life services looks like. And then we'll get into the good stuff. We'll talk about one of our success stories for Justin. So I think you can proceed to the 2 slides ahead. Next one here is just a title slide. All right. Okay. So we've been operating our life services program since 2017. Our vision and our mission has remained the same. So we don't just look at the individual's health needs, but we look at them as that whole person. So a whole person who's able to accomplish lots of things. They can accomplish goals related to their health. They can also accomplish those social driver goals. So financial stability, security in their housing, transportation, all of those different things. So we do this work by partnering with the member to remove their barriers, both physical and mental, so they're able to accomplish their goals through their own abilities and skills, therefore making them self-sufficient in the future. We believe that everyone has the ability to have a positive impact on their own life and just need that partnership to help unlock some of that. So our initial life services program was Job Connect. It's kind of our legacy program. For members in that program, they were specifically required to have a goal related to employment or education. Of course, the life coaches would still work with those members on any other contributing social driver, SDOH need, transportation, childcare, things like that. But we went ahead and started assisting folks, even if they didn't have an employment and education goal at the time, but maybe needed some stabilization in housing or other things like that. We do this with our 8 life coaches. They work regionally, so each life coach has really good familiarity with the resources available in the communities that they're working in. So if you want to go ahead and go to the next slide. So as the slide mentions here, there's no wrong door for members to get to us. They can do this by themselves. We have a self-referral form online, phone, email, and then we of course receive referrals from our internal partners, so folks from our care management team, and then also from our reentry team. Community organizations and providers can also refer members over to us to help with those SDOH needs. We complete different assessments. We use the Prepare here, so we make sure we assess for those SDOH needs. That way goals can be created and we can track those goals throughout the coaching relationship. There are a few different differentiators with our program, but one in particular is that we have an employer relations specialist here, and they help maintain our employer partner network. That way we have that direct pipeline and communication to HR departments at different employers, just to give that leg up and give a vouch and be able to express all the work that someone's done to get ready and stable for employment. And then we will support members for up to 2 years after they find that employment. That way they can potentially advance their careers or even start working towards other goals like home ownership and things like that. All right, so next slide here. All right, okay, so here's the exciting part, our success story about Justin. First, I always like to give credit to my colleague, Chad Carruthers, who writes these stories for us. He has a history in journalism before becoming an HR professional and then actually coming here as our employer relations specialist. So he is able to bring these stories to life. So I'll read through the story and then I'll refer back to the slide for some of those key points to hit. All right, so Justin will never forget the night that he slept in a porta potty. I've hit the lowest I can go, he remembers saying to himself. This is rock bottom. Upon release from prison, Justin had been dropped off at a homeless shelter where where another guest threatened him. Justin fled, and when he returned, he wasn't allowed back in at the time. He wandered the streets until he came across a porta potty that had been left unlocked in a parking lot. The sound of rain pounding on its plastic roof as he curled up inside is now permanently etched in his mind. Justin had one stranger's number saved in his phone. That would be Cord Hale, one of our community justice liaisons here at CareSource. Hale could help Justin not only with his medical care, but also the social drivers of health like housing and employment. There was no one else out there giving me resources but CareSource, Justin says. After assisting with initial stabilization, Cord referred Justin over to Life Services, and Life Coach Sierra Moore took it from there. Soon, Justin was in his own apartment, and Moore referred him to the right community partners for utility assistance and work clothing. She also has experience helping CareSource members navigate the justice system and help coach him through getting his fee payments cut in half from $300 to $150 a week. This was still a burden for him, so they continued to find ways to gain additional money to help remove that burden. At the height of the pandemic, Moore would even run to food banks and drop groceries off at Justin's back door. Everything didn't always work out in Justin's favor, but he showed tenacity, and then Moore assisted with his big break, a job in a paint department at a large automaker. In his first 6 months, Justin worked 6 days per week and had perfect attendance. He was soon promoted to team lead and even bought himself a Jeep. That's his dream car. Life Coach Sierra Moore says he's been thriving. Justin is now completely free of the justice system and recently let Hale and Moore know that he is being considered for a supervisor position. He says, you guys are a blessing. Nobody else had my back, but CareSource had my back. All right, so a couple of the key points I just wanted to hit on in that story. example of collaboration, like I said, we work with our internal partners here, the reentry team, care management teams, any other member-facing staff. We just want to make sure we can wrap these members up in support to get them stable, especially these folks that are returning to the community from incarceration. Court and Sierra also provided the member with community resources. At the end of the day, though, the majority of the work had to be done by Justin, which he did. Like I mentioned at the beginning, we place a big emphasis on self-sufficiency. If something happens to them in a couple of years, we hope that they were able to learn and grow. That way they can accomplish whatever barrier is in front of them down the road. So when resources weren't available, we were able to provide that extra support via our member assistance fund for things like gas cards. That way he could focus on work. And then lastly, the story talks about, it's more of a high level story. Like I just wanted to mention, he had setbacks along the way. There were a couple different jobs in the mix. He had to continue to work to find others. And that's where the life coach just kept encouraging him, working through the thought process on how he was going to continue moving forward. So with that, I will take any questions.
Questions for Shannon? Thanks so much for sharing. Next up, United Healthcare, we have Dr. Hodges, who I believe is in the room.
Absolutely.
Good afternoon.
In a nod to my Anthem colleague, the glasses are out and on. And when you talk about care management, I mean, we can talk about, organizational charts and flow charts, but the true success of care management is our success stories, and that's what we're going to try to tell today. And this is a real story of Sarah, who is our member, and Whitney, who is our member services navigator, who had a relationship for a long time prior to the evolution of this story. In October of 22, during a regular phone checkup, Sarah shared with Whitney that she had stopped taking some of her very important medications and that she was feeling very heavy, emotional, sad, and scared. At that point, her care services manager or navigator, Whitney, obtained the member's permission and established a three-way call with the member's behavioral health advocate, which is a care manager that specializes in behavioral care. The member needed a new psychiatrist to restart the medications that she had stopped. The psychiatrist's office had closed for the day during the call, so Whitney reassured Sarah that she would call her back first thing in the morning. And during that call, Whitney also connected Sarah with other needed resources and let her know and that she understood and that she would follow up with her. By the middle of the morning the next day, Whitney located a new psychiatrist with an in-house recovery program and scheduled her appointment for the member. Fast forward to a year from the initial call in October of 23 last year, through a number of regular check-in calls, Sarah has maintained her relationship with her psychiatrist. She remains on her medications, and she continues her relationship with her member services navigator, Whitney. More recently, just last month, when Whitney called Sarah to confirm upcoming appointments and transportation info, Sarah shared that she was in a much better place. Sarah shared with Whitney that she now has the energy to reach out and make some of those additional social resources appointments that she had been provided with. And knowing that Sarah had now had the energy to follow up on her own seemed like a huge milestone to Whitney. In terms of our important relationship that Whitney had with Sarah, as Whitney reflected on these calls, she was super proud of her member, but also proud of herself too, for working hard to get her the help with scheduling appointments, working with provider offices to ensure prior authorization requirements that were met, and for medications that were met, and also able to help her with the transportation needs to get to those appointments. And in her reflections, in her words, were that knowing that I made a difference really fuels my day. Enjoying this type of ongoing relationship with our most vulnerable members is a truly amazing experience. And I think with Medicaid, and especially with the upcoming Pathways program, we're looking at really trying to do that for our most vulnerable Hoosiers. So thank you for listening. If you have any other questions, I'd be happy to take those.
Questions for Dr. Hodges? No, thank you for being here and thank you for sharing. I think next up, Brittany, from our Director of Medical Management at MDWise.
Thank you.
Oops, I need to do the slide. Sorry.
No, good afternoon, everyone. Again, my name is Brittany, and I'm going to be sharing with you two member success stories that really show how our collaboration.
I'm sorry, Brittany, just a little hard to hear you.
Sorry.
Thank you so much.
Sorry. So today I'm going to be sharing with you two member success stories of how our connection and collaboration with members really drove positive outcomes. So the next slide, please. Our first story is about a 30-year-old female who has battled against sex trafficking, homelessness, and being incarcerated. She also experienced an opioid addiction and became pregnant. She battled hard through her opioid addiction, where she had not been able to utilize her medication-assisted therapy treatment and being connected to a provider. She had tried several and did not find that bond and that connection. So she often hopped from one provider to another and then unfortunately was never stable in her treatment and recovery. So when we identified her pregnancy, we were able to get her connected with our MDWise Indiana Pregnancy Promise case management team, and she was connected with our CM, Lauren. At that time of pregnancy, she did not have stable housing, nor a plan to live independently or care for her unborn child. Through case management interaction, she was educated on her pregnancy and postpartum care and connected to community resources. With these resources, including apartment and home basics, we were able to also help her get applied for the CCDF waiver, where she could gain childcare support, so she was able to find a job when able and attend her MAT treatment, as she was successfully connected to a provider during this time. She was in case management. Recently, in connection with her, we found out she was approved for Section 8 housing and has a plan to move into a 2-bedroom apartment with her young infant son and begin work 1 week afterwards. She was very excited for this, although very nervous, as she felt that it wasn't everything she had hoped for in a sense. She was nervous to be independent, with something she's never really had before. And now being a mother to a newborn and starting a job was just a lot. So her continued connection through our case management team and Laura, often, daily to every other day phone calls to kind of, make sure that she felt connected and supported. She is now doing really well. Is doing successful in her job and now has her infant is 3 months old. So we're excited to share that. Next slide. And the next success story we want to share, this member is an adolescent female who had been living with her guardian. She was admitted to a behavioral health inpatient facility due to multiple thoughts and attempts at suicide. The guardian was legally blind and required a seeing eye dog for mobility, so they definitely had some struggles between them to ensure she got the care that they need, and the guardian was able to support her. This inpatient stay, unfortunately, was 2 hours away from her home. And once the member was discharged, we found that in connection with the case management, we were trying to ensure that she knows she had a safe discharge plan. She had the medications that she needs. She was connected to a provider outside of discharge that was closer to home. Her pharmacy benefits, we found out her medications were not sent to the correct pharmacy. So the guardian became very worried. She did not want to get the member, back to another facility, especially 2 hours away. And we were able to work with the facility, her new provider for her behavioral health, as well as the school to make sure she had a safe plan, her pharmacy connection with her medications there to maintain her treatment, and overall ongoing goals to self-manage, not only for the guardian, but also the member. And they continue to interact each other on a weekly to bi-weekly basis.
Fantastic. Questions for Brittany? Thanks for sharing. It's interesting to hear a story of a minor case management as well. That was, and a great connection to Pregnancy Promise, which we talked about at the last meeting. So thanks. connection there. Okay, and certainly not least, but up last, Dr. Shara Wesley from MHS.
Hey,
Thanks for being here.
thanks for having me. My name is Shara Wesley, and I'm really excited about being able just to share how we are connecting community resources to our case of care coordination services. So I'll get started. Many are familiar because it's very popular, not just in the state of Indiana, the dynamic impact that doulas can have on both maternal and infant outcomes. And through our work with the ONPP work group around doula support, we also recognize that there are a lot of challenges with just capacity within the doula network. So doulas having burnout, but then also for individuals that are interested to become a part of this type of support, not really having a mechanism to do so. And so before we can even look at how we connect doulas to our care management services, we first wanted to look at how we could support doula access for all in the state of Indiana. So here I just am highlighting two kind of programs that we're doing, one in partnership with the Indiana Minority Health Coalition, which has coalitions throughout the state of Indiana. And a major part of what they do or provide within communities in Indiana is their doula, community-based doula program. So these are doulas that are providing support and birth advocacy within the community. So it's not your boutique or private or very, upscale doula service. It's really local, hyper-locally based provision of services for women that would maybe not otherwise have the means to pay for this type of service. So through our partnership with IMHC, we're actually providing sponsorship of a doula. We're really excited to have this doula that is providing bilingual support. And we saw dynamic outcomes for the 27 women that she was able to serve just in one calendar year. With those outcomes, 81% of those births being on time or not preterm. Everything from those infants also being a part of safe sleep practices, which we know is a huge education throughout the state around to mitigate SIDS. We also saw that these women were able to not only carry their infants to term, but also the mode of delivery not being through C-section. So can share more on that, but very excited about that partnership with Indiana Minority Health Coalition. The other thing I'll kind of highlight here is our partnership with the Indianapolis Urban League. So they have a really dynamic workforce development program. And through our work with them, we learned that they actually had a lot of participants in that workforce development program that wanted to either become doulas or lactation consultants or a newer certification, which is like a perinatal education, similar to like a community health worker certification, but that has an emphasis on perinatal care and support. And so through our work with the Urban League, we are offering scholarships through their workforce development program to increase access to doula education, doula certification in the state of Indiana. And so on the next slide, I'll get into, okay, so what's the so what? I've said a lot. It's how we are looking at embedding doula support in some of our more traditional population health care coordination models. So how can you have a health equity lens embedded in equality lens? So our goal is always to provide quality care to all of our members, but how do we reach those members that maybe need a little more wraparound support or things that are culturally appropriate or show up in a way that resonates with them to support their journey into parenthood. And so I have here just kind of split screened is our Doula and Me program, which is a new model where mothers that are also a part of our special deliveries program, so high risk, can also opt into a Doula and Me program. Through that program, they have the clinical support through a more traditional care coordination model, but then they also have more of a patient member advocate, social support, and lactation support through the Doula and Me program. So both of these programs run in tandem. We recognize that a lot of our expecting mothers need both, but for those that are identified as particularly high risk, how we can bring these two elements together. So providing that very relevant community-based support, but that's still paired with evidence-based practice and what we do well around clinical support. So I'll go into our success story to kind of drive it home, bringing up the rear here.
So how do we see kind of the social support needs and how it impacts our moms? And so this is a story from actually one of the teams I get to oversee, which is our social drivers of health team, where their care coordination referred this mother to our team because she had some really complex housing needs. And for anyone that's working in the housing space, typically when you're not helping a member or a person in the community navigate housing challenges, it's not a one-step fix. It's not, they just maybe need rental assistance. There's usually a lot of compounded things that are occurring. So this particular member was housed, but what we would consider unhealthy housing. So rodent and insect infested to the point where it was kind of some erosion in the walls and floors and not really knowing kind of what to do. So she got with our SDOH specialist, and she really provided a lot of education on self-advocacy. So how she has rights around her Section 8 vouchers, that there are also people that will step in on her behalf. And so with her permission, she did a 3-way call with the housing authority, shared a lot of the challenges that she's experiencing in this housing. Again, something the member didn't even know that she could do. The housing authority then ordered an emergency order to have the house inspected and to, put the landlord on notice, so to speak. Again, something our member didn't even know that she could do. And that if the housing things were not corrected, that she could be rehoused. And so being able to provide this education for her wasn't just about fixing what the acute crisis was, which is that we wanted her to be in a house that's healthy, but also really showing her that people care about her in the state of Indiana and that there are protections in place to really oversee or protect those that are part of some of these programs. So ultimately, just to kind of close out, we were able to rectify the situation. And so we look forward, this is a pretty new story, so we look forward to see if she is going to end up moving or if the landlord was able to rectify the situation in a timely manner. And any questions?
Questions for Dr. Wesley? If not, I just want to say thank you so much to all 5 MCEs for sharing this. I think it's really inspiring and helps us connect to the larger policy and programmatic pieces that we're discussing as a group. And so want to continue sprinkling some of this in future MAC meetings and appreciate their willingness to be a good partner in that. So thank you very much. All right, that concludes sort of the substantive pieces of our meeting. I think comments? If not, our next meeting is scheduled for May 22nd, which sounds far away, but we'll be here before we know it. May 22nd, Wednesday, 1 to 3 p.m. again, this time in the afternoon in a hybrid format. So thank you all for joining remotely or in the room, and thank you to our guest speakers today. With that, we are adjourned.